views, information, or opinions expressed during AAOA broadcast series are solely those of the individuals involved and do not necessarily represent those of the American Academy of Otolaryngic Allergy, its employees, or members. The AAOA is not responsible and does not verify for accuracy any of the information contained in and assumes no liability for any activities in connection with these broadcasts. The primary purpose of this broadcast series is to educate and inform and does not constitute medical or other professional advice or services. Advertising which is incorporated into, placed in associate with, or targeted toward the content of this product without express approval and acknowledgement of the AAOA is forbidden. These broadcasts are available for private, non-commercial use only and may not be edited or modified from their original form or reproduced for distribution.
Hey, welcome everybody. I am Carlos Ebert. I'm happy to have everybody here today, and we're talking about surgical priorities. And first, I'd like everybody to just introduce yourselves. Tell me where you're practicing, whether it's academic or private. What % of your practice is surgical versus medical, mix of peds and adults. When you went into reduced practice, and where are you at in the reopening aspects? And we'll go in alphabetical order. We'll start with Dr. Dawson.
Hi, I am in Southeast Iowa, practicing private practice, and I do allergy as well as general otolaryngology and sleep medicine. The dark day was March 13th. That was my last day in the OR. The latter part of the weekend, found out about everything being canceled. Lost about 46 or so cases that had been scheduled out the rest of the month. And we are tomorrow morning starting back with my first reboot of surgical load. So it's real constricted down, and we can talk about that. And I have no conflict of interest as well in any of this.
Okay, thank you. I'll go next. I am Carlos Ebert. I'm in Chapel Hill, North Carolina. I work at the University of North Carolina, and I have a mix of surgical and medical practice and endoscopic skull-based surgery. I don't really see any pediatrics unless it has a really complex sinonasal issue. We went into reduced practice just after that, just around the third week of March, and we began reopening from an operative standpoint this past Monday, and in some select elective cases. And clinic-wise, we are just now reopening as well this week for some selected patients. Dr. Lowry.
Hello, I'm Adrienne Lowry. I am in private practice in Bellevue, Washington, which is right next to Seattle. So I have about a 70% adult, 30% pediatric mix, and do usually about 1 day a week of operating, which stopped in pretty early on since we were hit pretty early on. So in the beginning of March, we stopped operating. And we actually just restarted about 10 days ago. Not with everything, and I can get into that more, but we just have been operating now more extensively for about 10 days with plans to fully return in 5 more days, not that anyone's counting.
Okay. Dr. Rodriguez.
So I'm Kenneth Rodriguez. I practice in Cleveland, Ohio at University Hospitals of Cleveland. It's an academic center. I'm about 50% of my revenue comes from surgery, about 50% comes from clinic. Like Carlos, I see almost exclusively adults unless a pediatric patient has a complex sinonasal issue like in cystic fibrosis. We went into reduced practice in mid-March, and as of early March, we began doing more elective cases, and our clinic schedules are reopening as of next week.
Excellent. Dr. Wilson.
Hi, my name is Kevin Wilson, and I am in private practice in general otolaryngology in Salt Lake City, Utah. And I do about a day of surgery a week, and we started slowing down about the same time. We actually never stopped completely. In the clinic, my patient flow slowed to a trickle, so we reduced our hours to basically a half day a week for a couple of weeks. And that was a few weeks ago. Now it's starting to slowly ramp up again. I stopped doing surgeries for the most part. And 3 of the 4 places that I operate are as of now fully, we can do all cases, or at least we're able to. And 1, we can just do time sensitive cases still. And I see mainly adults, about 15 or 20% pediatric, and I have no conflicts of interest.
Oh yeah, I forgot to say that I have no conflicts of interest except for I'm a consultant for our client. Appreciate everybody's time tonight. I think it's important to realize that, as we know, there's a lot of new data coming out daily, so things change and recommendations change. So we're going to use, obviously common sense measures, and we must be fluid to adapt to the new landscape. And we're going to start this by sharing our thoughts on various aspects of where we are in our experience. So our first topic is going to be our experience. I'd like everybody to kind of just give your thoughts about where we're going from a busy practice to slowing. How did this affect you? Was it a financial thing? Did you fully stop during the height of the pandemic? Did you do some emergency stuff, any elective things? And then after that, we'll go into on how to restart and what everybody's thinking about that. So we'll start with you, Dr. Rodriguez.
Well, I think, for me, the big change was that I'm in this big academic center. And so they immediately, once Ohio got rid of elective surgery, our practice came to a complete standstill. The emergent stuff that we see, so pituitary apoplexy, invasive fungal sinusitis, we were just watching out for those patients and creating protocols that if they came in and they were unable to be tested, they would either be done endonasal with full, complete, PPE, and even neurosurgery was talking about during craniotomies to do those procedures. So from a surgical perspective, we came almost to a complete halt. From a clinical practice standpoint, we basically went to 100% virtual visits. There were several weeks that I did not see a single patient in clinic. Individuals that needed to be seen were seen through our Seidman Cancer Center, which is a place where they're processing equipment at the level of our operating room. And we would basically rotate patients into whatever attending was present in those clinics. And then we would directly communicate with those folks. So from a perspective of UH in Cleveland, we stopped all elective procedures, only emergent procedures. And then, the big takeaway for me was I was amazed at what I could accomplish via a virtual visit. I think a lot of us forget that a lot of what we do is communicating with patients, getting a feel for their symptoms, what bothers them. But at the end of the day, your clinical exam will, of course, change things you do. But a lot of your feelings on your experience can really guide where you go. And I feel like that patient care was still at a high standard. But it's certainly, now that we're going back, we have a number of individuals are coming in now. But I feel like during that 2.5 month block, that overall people who needed to be seen were seen. But so much could be taken care of virtually.
Yeah, I agree. I think we underestimated how much we could do via that avenue. So Dr. Lowry, how was your experience?
We significantly decreased, not quite to that same extent, so it wasn't completely dead. It was a trickle, as Dr. Wilson said, but for us, we surgically still did a very few select cases, like cancer cases still were occurring, and kind of anything that basically could harm the patient within the next 3 weeks was kind of our guideline. So anything that would cause them to have a poor outcome because of delaying care for if they delayed more than 3 weeks, we were allowed to kind of proceed with. So we did that for about, like we said, almost 2 months. And then in the past 10 days, we've come up with this, a lot of people in my group have put a lot of work into this elective tier system, similar to what the American College of Surgeons kind of put out there. But basically, and then they combined it with this communicable infectious disease threat level. And so you basically take your tier of, priority of surgery and the level of threat that is in our environment, specifically in Seattle right now, and you can find out what surgery you can do based off of that. And I can show those tables then. But so we are now at a level tier 2A, which basically means anything that could hurt the patient in if left untreated for more than 3 months, and they are an ASA class 1 or 2. So not the really sick patients. Still ideally should not do them until we return to a communicable disease threat level 1, which might be a while. But some people put a lot of thought into this, and it's getting better, and we're expanding more. But at first we were doing a lot less, obviously, pretty much like everyone else.
Sounds pretty complicated, though.
It is. They've made it as complicated as possible. Yeah.
Dr. Wilson, how about you?
I'm in Utah, and Utah was hit less, I think, than a lot of other places. Our rates are still relatively low, so we never shut down completely. We incorporated telemedicine into our office as an option for patients, and I've had a few people take it, but really not many. And so most people are just still coming in if they feel comfortable. As the threat level has reduced and we've started to open things up to elective surgeries, it's been interesting because it hasn't necessarily translated into a flood of patients wanting surgery suddenly, as I thought it might. You know, I've got dozens of patients that need surgery and are ready, but when we call them and say, hey, we're able to schedule your surgery, it's interesting, at least half of them say, I think I'll just keep waiting until I feel more comfortable. And so they're sort of self-selecting to continue waiting even though they can. And the other patients, of course, jump at the opportunity. We initially were doing some of the not emergent but not totally elective, like maybe thyroid cancers that could wait but probably should be done before too long. And now we're expanding into other more elective opportunities.
Sounds good. And Dr. Dawson.
Okay, so yeah, as I mentioned before, I stopped everything. Last day in the OR was Friday the 13th in March, and on Monday the 16th we started kind of canceling out elective cases. I did have some supraglottic tumors needing biopsy, things like that were taking care of that last week, and then we also shut down all clinic and stop immunotherapy. Now that was only for a quick, short 2 weeks. We then started back up immunotherapy. We were seeing in the clinic only a handful did start up phone and followed by telehealth. I'm an employed physician. I'm in a large multi-specialty group that spans 3 states. And so there were a lot of resources. We in fact didn't have any financial impact. We were guaranteed salary through the end of May, and then have since, because of the losses that the system has sustained, we are now have a 10% rollback. But it's a situation compared to a true single solo practitioner type of shop. It's a much better situation. So we're back, like I said, starting elective cases tomorrow. We're using that aerosol generating procedure kind of method of screening. We're going for the low-hanging fruit first, only going through all the protective things as we need to, and taking a patient in terms of testing and things before we take them to the OR. They have to be tested 48 hours before going to the OR, and they have to be obviously negative. And even the babies for myringotomies that I'm going to be doing tomorrow, which is where I'm starting out with really non-aerosolized aerosol generating procedures tomorrow, they're tested. So, and that's all determined by our large system, even though Iowa, as Utah was, has been relatively lightly bothered by this. We are at about 10,000 cases statewide, and just over 100 in terms of fatalities. So not as bad as Seattle, not as bad as the East Coast. So
right. So yeah, and our practice is very similar to Dr. Rodriguez in the sense that a lot of our endoscopic skull-base surgical procedures, we did not stop. The people had tumors or apoplexy. Things are more on the emergent basis. But any procedure that was deemed elective, meaning that they could delay greater than 6 weeks, we canceled and postponed. We have just started opening back up those patients. We call them semi-elective, those patients that have been put off. And like Dr. Wilson was saying, we've had that same experience. I have a lot of patients on the schedule, but not everybody's jumping at it to get surgery. But that really leads us into our really next topic, like how do we restart? Who determines it? Does your health system? Do you determine it? As Dr. Dawson was saying, maybe some less risky, less airway procedures. How about PPE? What are you doing in the OR versus what are you doing in clinic? How are you scoping people? Are you doing something different? How are you overcoming patient COVID concerns? What is your protocol for COVID testing, for example? So just touch on some of those, and we'll go in reverse order this time with Dr. Dawson first.
So we are testing everyone have to have a negative test before they go to the OR. We are doing things in the clinic, I mean, that are pretty much like times of old, but we are masked all the time. We do N95s if we're doing any procedure. I do nasal endoscopy, flexible laryngoscopy, epistaxis, minor type things that come into the office. And we are just doing a lot more in terms of masking. I have found a great difficulty in converting to using a face shield as well. When I'm doing epistaxis, I just use these glasses, which is a concern. Other than that, face shields and things like that when I'm doing anything else, as well as the N95s to take care of things. And like I said, everything in terms of policies and procedures is a system-wide event and system-wide documentation. And we're on Epic, so it's pretty well standard across a large
So
system.
are you using different N95s for every clinic day or multiple days?
We have this strange occurrence where we had an excavation company, why I don't know, had donated to us a couple cases of N95s. We are one clinic that has no shortage, and it was to the ENT clinic at our so we are using daily N95s and rolling them over.
Perfect.
Right now.
How about you, Dr. Wilson?
Yeah, I mean, like I said, we never shut down our office completely. We just implemented safety measures. We all wear masks if we have patient contact. We wear N95s and more protective equipment, face shields when we're doing more risky surgery or procedures like scopes and epistaxis control. The operating room, I'm still trying to figure out where I stand on that. Initially we were wearing N95s for everything just because of the intubation and how the possible transmission for up to 15 minutes after. So we were just wearing them throughout. And now every patient is being screened 3 days before and then really quarantining themselves after to make sure they're negative. But there is a reported, low but not zero incidence of false negatives, and so we're still taking precautions. Whenever I'm doing surgeries, I'm still wearing my N95s throughout, even though my bridge of my nose hates that. But that seems to be working out fine. And as far as I've always felt comfortable caring for the patients. I think if it was a higher risk area, I may have stopped doing scopes and maybe stopped doing some of the things I do, but I've never really felt that much of concern where I am. So my only limitation is just helping patients overcome their fear and come out of their caves.
So how about staff? Like when you're coming to the office, are office staff screened in any ways? There's some screening process for healthcare workers?
Or every person that comes to the door gets a temperature screen, including staff. And when they call and make the appointment, we just remind them that if they have those concerning symptoms, that they aren't welcome in our office and that they should go elsewhere to seek care, and we'll care for them once they're over their acute illness.
Exactly. Okay, Dr. Laury.
So we're doing a lot of the similar things, and I think there's a couple of things I think we do that I really do like. Some of them I think we have to do because so much is unknown, and to be as safe as possible, we should probably do them. So we do wear N95 masks. I wear an N95 mask for every patient that I operate on. Every nurse, every patient has a mask on that comes into the surgery center. We don't let anybody else into the surgery center with that patient. There's no people in the waiting room, except if it's a parent. We do allow that. We are testing all of our patients before we operate on them, except for very small children. That's a personal decision in our private practice that we've decided to do. Another thing and this is one thing that I think is actually quite useful that I didn't, was thought about by one of my partners, is every 7 days for 21 days after they have their surgery, every patient gets a text message asking if they've been diagnosed with COVID, so that we can work on our contact tracing, because our state is really getting into this contact tracing stage of reentry. It's a very big push of our governor, and everyone has to be where they've been for the past 2 to 3 weeks has to be able to be tracked. And so it's one way to identify if anyone does pop positive and might have exposed staff members, other patients, who should we test next? Who should we call up and say, you've been exposed at our facility potentially, they were there on the same day as you, you should get tested. So that's one thing I actually really like, that I think is, thoughtful and could be useful for eliminating spread. One other thing that we do that I don't know if everyone else is doing, or we wait after every single case for 30 minutes, which is 4 air filtration cycles in our OR. That's what's recommended right now. A lot of the hospitals that I work at have gone away from that, but we're still doing it right now.
Yeah,
Probably,
I like that that contact tracing. That's maybe something that other practices can think about.
I liked that too. It's really easy. Yeah, when our surgery schedulers schedule it, they just put in 7, 14, and 21 days after, the patient just gets a text and says, have you been exposed to COVID or diagnosed with COVID that you know of? And they just respond back. So I think that's a really great idea. And I would encourage other people it makes sense to me with regards to all this. Some of these things that we're doing, I don't know if it makes sense. Honestly, it makes people feel safer, and that's good. But that one actually, I was like, this makes sense. This actually could make a difference.
So Dr. Rodriguez, do you do anything different or anything unique that you could share with us?
Well, I think in terms of masking, I mean, we're wearing N95s for everything that we do. And everyone in the room, if we're wearing an N95, they wear an N95 too. One of the other things we're doing is we're calling patients, 7, even 14 days before their procedure, strongly encouraging them to social distance, asking them if they have any sick contacts. 100% of people who come in to our health system get not only temperature screening, they're asked questions. This morning I was asked, not only do I have any symptoms, have I been exposed to anyone with symptoms? Because we're really trying just to separate out people who could be at risk, because as we all know, the test is not perfect. If you get into how the test is done, if the swab is not put in the right area, it can be negative. So there's a lot that goes into this medical decision making. I wanted to go back to what Dr. Lowry said before about this tiered system of what was going on. It was profound to me how much of what I do is elective, because I consider myself really making people's quality of life better and feeling some measure of importance based on that. But the people who are running all our rooms every day were the cancer surgeons. And I talked to our senior cancer surgeon. He said that we barely slowed down because those people were screened, brought in, had their necessary care, but it was everyone else who does a lot of quality of life surgery who were pulled back. At our system, we had limited amount of full PAPR, essentially the spacesuit-like outfits. So it was very, very difficult to get your hands on that. And therefore, anything that was not deemed critical was not done. In terms of your question about how are we educating people about COVID overcoming concerns, I can't echo enough. Whatever my surgical backlog is, 1 out of 3 people wish to defer because they're having elective surgery and they have concerns. But I think what's important to tell every patient is everybody is screened, everybody is tested. I can't speak to the health systems that you all work in, but my health system, the hospitals are very light. The exposures are actually very low. The nurses who pre-op these patients are incredibly self-aware. We are really trying to limit exposures in and out. And in Ohio, we're doing the same day procedures. So people aren't being admitted, so they're not having that exposure unless their disease process necessitates it. So I think if they have a desire to have a procedure and they go through the necessary protocols, I think it is very safe to have surgery now if we're all being thoughtful and aware.
That's the very truth. So in our institution in Chapel Hill, we test everybody 48 hours before surgery, and it has to be within 48 hours. And their test can only be at UNC, which is very difficult for a lot of our patients as they travel 3 to 4 hours and they have to come in for their test. We do occasionally accept tests from other institutions, but it has to be within 48 hours of the surgical procedure or they'll be canceled. We also have a very complex and very nuanced tier system based on number of patients with COVID in the hospital and community stuff. Which changes weekly, if not every other day. So it's a moving target. But we currently have just started these, as I'd mentioned earlier, these somewhat semi-elective or patients that have been put off for an extended period of time. And like you, Dr. Rodriguez, some of my patients that need surgery, and I would almost say they're a priority, because if patients were deemed a priority, we continue with their care, still are not wanting to proceed. I've seen a few video visits, not a ton. Not everybody has got that capability in our area that we see. I have seen a couple patients that had imaging prior to seeing me that have been treated appropriately, and I have scheduled them for surgery just based on my virtual visit because I have imaging and they've been treated appropriately. So I was just wondering if anybody else has done that, had a virtual visit and scheduled them for surgery on the virtual visit.
Well, we absolutely have. I did my first 2 folks actually earlier this week. Just for a number, University Hospitals has done 100,000 virtual visits since this began.
Wow.
We're on multiple different systems doing it, and it was a global initiative by our system to do so. So has it been without its hiccups? Of course not. But our system is very invested in it. They remain invested in it. And moving forward, they intend to make it a big part of what we do. There's a lot that goes into never examining a patient and then operating on them. But if they've done adequate medical therapy, they've been imaged and have persistence of mucosal inflammation and the necessary symptoms, I had no issue with it. The procedures went very well and the patients were very satisfied because, again, it minimized their exposure. Where we go after the surgeries, we'll talk about in a little bit. But I think that process, as long as it's been thoughtful, the technology works so that you can have an active exchange of ideas and questions, I think it's very valuable, especially now.
And I was going to say, we also have a very complex scoring system for patients that it's like a risk stratifier, more or less. If they're being intubated, they get a certain score. If they're having a surgery on the head and neck, which increases their score substantially. And if they're over a certain score, even if they're considered the semi-elective or somewhat priority, they do not schedule the surgery just based on that risk stratifier. Again, it's very complex and it changes a lot. So I'm going to move over to a little bit more of the nuts and bolts kind of stuff. A question that kind of arises is, how's your practice taking care of the backlog? We had mentioned a little bit about it. Do you get increased block time? Is there more availability for you to operate with the backlog? Are patients discussing more of their fears about scheduling surgery? Is there anything we can tell them to alleviate that more than what we've said? How about your own family? Is there anything that you talk to your family about risk? We'll start with Dr. Rodriguez on that one.
Yeah, in terms of the backlog, since we started this, it's been a big administrative shift. So my nurse went from coordinating things in clinic to essentially tracking our surgical patients who were canceled. And there's a number of big components that we get into. Many of us in medicine have been lucky and our jobs have been spared and we've been compensated. But in the general population at large, as you've seen, the unemployment rates are skyrocketing. So unfortunately, a large number of patients that I would have operated on in the last 2.5 months have lost their insurance or are not financially able to cover the costs of surgery. So our policy was, we created a system where if we felt like they needed to be done within 2 weeks, so something that, as was mentioned earlier, would dramatically impact their life, they became our tier 1. They were contacted quickly and scheduled. People that should be done in 2 to 4 weeks, a CSF leak, for example, someone you want to get done but doesn't become emergent. And then the elective nasal polyposis CRS population was over 4 weeks, and they were called in that order with preference given to the people who have waited the longest. For us, and again, this is speaking from an academic institution, payer mix didn't make a difference, whether or not, frankly, they were insured or not insured based on what they could work out with our health system. And in terms of what I tell my wife is an asthmatic. I have a 6-month-old at home. When I get in my car in the morning and I drive to work, I strap on my mask, I wash my hands, I don't touch my face. But I feel like it's my responsibility to go in and do these things, but I'm as safe as I can be, and I'm really proud that my institution has really supported that. But I do have frank conversations with my family at home about the risks. But again, we're testing everybody. Everybody has appropriate PPE. So I think that within this environment, risk has been minimized as much as it can be in my system.
Right. How about you, Dr. Laury?
The most interesting thing is, what do you tell your family? Because you are at an increased risk. And my husband, who's working from home now, he says, well, if someone's going to bring it home, it's you. And probably it is true if it's going to be, but, what I've seen and what I've heard and what I've read about this is, we're doing everything we can to be safe. We're all wearing masks. You're changing your clothes. You're washing your hands. You're doing I can't imagine us doing any more to try to prevent this. And we have all the equipment to be able to do that, really. So I overall feel safe. I tell him it's going to be okay, to not worry, that I'm not going to bring this home to him. Hopefully I know how to control this, because I really still do believe that the majority of spread of this disease is close person-to-person discussion or contact without a mask. And I think if we're avoiding that, which we are in my clinic, I wear a mask just to talk to a patient, and they wear a mask to talk to me, and they take it off when I examine them. But I think as long as we're doing that, we are going to see 99.5% of the infections not occur, if you can do that. Now, obviously you can't do that in all situations, but we're at the point where we can. So I feel overall very safe, and coming home to my family at the end of the day.
How about you, Dr. Wilson? Anything you are telling your family?
I agree with those comments, and one of the institutions that I work with has actually studied that, at least in our institution, our infection rates, transmission rates, any higher in healthcare workers compared to the public, and at least where we are, they're not. They're actually the same, and some actually have shown a little bit lower. So I agree that taking those appropriate precautions does not necessarily put our families at greater risk. I feel like some of my teenage kids, who I can hardly keep home and away from their friends, present more risk to our family than maybe what I'm doing. So I sort of view this less as that I'm worried about my family, and more I need to do these things for a public health reason. And that's what I tell my kids. We're not really protecting ourselves when we wear masks. We're really protecting the public. And so it's more of our civic responsibility. I don't know what that does for a teenage mind, but it sounds right.
I agree. Dr. Dawson.
Yeah, I would just echo those things that, our schools have been out since that 12th of March. And so all of this cadre of young people that are around the town and being really active are really where the risk is. But nonetheless, we mask all the time, with staff. I don't necessarily wear that N95 all the time, but I certainly wear a mask all the time. Even when we have huddles, even when we have discussions, we are distanced compared to what we normally would do. We're not gathering in the break room as a bunch of folks and having a potluck lunch, those kind of things. And I think we're doing what we can. Having said that, I don't think it really matters that much. This is a virus. They will be transmitted more than we can ever imagine, but we're doing what we can. And that's the conversation I've had with my family. But I certainly am the one that, until I get all clothes changed and showered and stuff, I'm socially distanced from not myself, but of the family. So
yeah, we have nothing really different in this household. I change clothes after seeing patients. I have a fresh clothes, come home, wash the hands, and do the best we can. I think, obviously there's only so much we can do, and the risk is what it is. But as long as we minimize it, doing everything we know, I think that's the best we can do for our family and our patients. So getting a little bit more drill down inside the OR, are you all present for the intubation, extubation, any special filtration in your OR? I know Dr. Lowry talked about you have to wait a certain amount of time for that filtration. Are you guys doing any drilling or electrocautery? Anything different that you're doing now because of the current crisis versus before? We'll start with you, Dr. Laury.
Well, like I said, we do wait a certain amount of time. 30 minutes is for air filtration cycles in our OR. The anesthesiologist does put a filter on all endotracheal tubes right now. I am there for the intubation. I have always been there for the intubation since I was a resident. I was taught you're always there for the intubation. I'm still there for the intubation. It's drilled into me. And having had all those patients be tested beforehand, I have very little issue with being there, and I'll probably continue to be there. So otherwise, there's not much else that we're doing differently in the OR besides waiting.
How about you, Dr. Wilson?
I feel like if the patient's been tested at negative and we're wearing our personal protective equipment, which is N95 masks. And we've taken all the precautions that we can. We're not delaying. When they first opened up the ORs, they were delaying 15 minutes for that 95 or 8% of the air to be recycled. And we've moved away from that now. I think that with the other precautions, at least where I am, I feel comfortable with in that environment. And it seems like everyone else does too.
Okay. How about you, Dr. Dawson?
Yeah, I'm starting tomorrow, but the protocol is that we're being asked to leave during the intubation, but Dr. Laury, I will not leave the room. It's just the way I've always been. I'll be in the corner with my N95, but I think we're airway doctors secondly in the situation like that. So other than that, yes, we are limited in the number of procedures that we can do. So our schedule is much different. I used to be able to, I had 2 rooms. I'm in a small community hospital and I have a block. And so I actually get 2 OR rooms and it's just ideal. I can get 15 usual general ENT cases done by early afternoon, 1 o'clock, 2 o'clock, starting at 7. Can't do that. It's down to 1 room. We're limited to 3 cases each day of this week. Next week, it's going to go to 5, depending on how things go. It's been very strictly regimented, and it's not anything to do with ENT. It's just in general OR cases. They haven't been specific by specialty, unfortunately.
How about you, Dr. Rodriguez?
Well, I think you bring up a great point, and it's so when this happened, university hospitals contracted basically everything went into our main campus. They even went as far as to shut down emergency departments and a lot of our satellites. So there was a time very recently that we were only seeing patients within our main campus, only operating within our main campus. Tomorrow is the first time I will go to our satellites to operate. So then it begs the question of when are these people being COVID tested, under what circumstances, how reliable is it? We are doing chest x-rays on our patients as an added level just to help perhaps like diagnose someone we otherwise wouldn't. There was talk in our system about testing people twice because the data that we were seeing was there was a 20% false negative rate, but the issue is being able to coordinate that. For us at the main campus, I agree with everything everybody said. If they're COVID negative, they're screened as negative, I feel very comfortable being in the room. As a general rule, for us, because we have residents, I am not necessarily in the room for intubation and extubation, but typically now I'm just outside the room in case anything comes about. That has less to do with COVID and more to do with just the way that the operating rooms run at my system. Our residents up to a week ago were not allowed to operate with us. We ran the rooms by ourselves. We woke people up, put them to sleep by ourselves. When this initially began, we're bringing in all sorts of technology into the ORs. They were only running certain rooms with certain pressure systems. They were bringing in lighting systems. A lot of that's gone away. Not to be flippant, but our rooms take so long to turn over at the main campus that air has circulated 100 times before we get in with the next patient. So that becomes a non-issue. Going back to what we're doing, we are not changing anything in the sense of drilling, cauterizing. There is data to say we are really aerosolizing the virus. And it begs the question of, we have been forever inhaling this stuff, and now we're becoming so aware of it. But if all these screens are in place and they're testing globally negative, we're not changing how we practice. If they do test positive, that's when the higher level of PPE would come in, but we're not changing what we do on a daily basis because of the screening process.
Now, have you operated on any COVID positive patients?
No, I have not. Our system contracted very early, and our ICUs between university hospitals and Cleveland Clinic were able to absorb the volume of people who needed them. So unlike what we were seeing out of New York City, Cleveland, Ohio never got to that level. I'm not entirely certain that anyone in my group has actually operated on someone with COVID outside of perhaps tracheostomy. So we've been fortunate in that regard, but it could be because we contracted very early in the process.
Has anyone else had any experience with a COVID positive patient? No.
I have. I was on call last week, and because we peaked early, it's very interesting. I'm seeing a lot of post-COVID problems. So I was on call. I got 3 consults in 1 week, which is a good amount, just for shortness of breath and dysphonia, all different patients after COVID diagnosis. All had been intubated. One gentleman had he had a trach. He had been intubated for 2.5 weeks when he got trached. He had post-intubation phonatory insufficiency. I had one lady who got posterior glottic stenosis, and she came into me with one of the earliest posterior glottic stenosis I've ever seen. I didn't know what it was. It would look like this beefy granulation and hadn't completely fused everything yet. And luckily, one of my partners is a laryngologist, and I just pulled him into the room. I said, "What is this?" And he was able to resect it. And luckily, our cords are moving today, which is about a week out. We'll see if it comes back and if we saved it or not. And then I saw another person with a vocal fold hemorrhage, interestingly. It's all COVID positive. All of them had been extubated. All of them had been intubated. All of them had been extubated. All of them had been COVID negative by the time I saw them. They had 2 clearance screens, so I was able to go in and scope them in the hospital and feel comfortable about it. But very interesting. I really wonder if we'll see an increase in these types of laryngology complications. I don't know if there's something about the virus. I don't know if it was just bad luck with the slew of intubations. But it was interesting. It's more than I usually see when I'm on call.
And people are being intubated probably a little bit longer too, so that's another
Yeah,
thing. Trachs were
exactly.
Trachs, after a short-term intubation, and now it's a little bit later because of COVID.
And now everyone's like, "Oh, don't touch them. Oh, don't aerosolize. That's an aerosolizing procedure. Avoid. Let's tie them over a little bit longer with a endotracheal tube." And it could be, yeah, it'll be interesting to see.
Yeah, I can't echo that enough. There were policies at UH where they were letting people sit on the vent much longer than they typically would because of that. So I think that it's almost a certainty that we will see in the next 6 months much more tracheal stenosis, glottic stenosis, all these sorts of things. And it'll beg the question of how comfortable are we all going to be now operating on these people who had the virus, knowing that you can become reinfected with the virus. So it'll bring up a lot of interesting components for our laryngology partners, who are likely one of the highest risk groups outside of rhinologists, because they are also getting coughed on and sneezed on during their procedures all day long.
Adrienne, did you follow any testing for antibodies or anything like that? That's just academic interest. I mean, did you test them for antibody?
No, we didn't test them for antibodies. They all had at least 2 negative COVID tests when I saw them. All of them had been cleared twice, supposedly the virus. And it was, I'm trying to think, one of them was 6 weeks post his positive test, one was 4 weeks, and 2 were 4 weeks post their positive tests. So in theory, yes, based off of what we know about the virus, in 4 weeks, your body should clear it. Granted, they were severe, but they had 2 negative tests and supposedly cleared it. But we did not get antibodies on them, no.
Interesting.
Well, I'm curious. So now that we're essentially all going back, is anyone going to change their postoperative follow-up, what they're going to do with patients after the operations in this environment? For me personally, I'm still seeing people back at between 4 to 6 days for their first evaluation and about a week after. But it does beg the question of how many more visits will I bring them back, especially if they're doing well. Dr. Wilson, are you going to change anything you do now that you're going back to the operating room and seeing people?
Yeah, I thought about that, and I think at least based on the current trajectory of where things are here, I probably won't. But there's a lot of unknowns coming up. Everybody, our state as well as many others are quote unquote opening up, which we'll see if that translates into more prevalence, and I could change that. But I think for now I'll probably continue what I'm doing. I think there will be more interest in telemedicine going forward, and people will just be more comfortable with that modality. You can't scope somebody on a telemedicine visit, but some patients may have some very good adequate follow-up. I was thinking allergy patients are excellent candidates for telemedicine visits. I mean, every 6 or 12 month follow-up visit to just kind of check on how they're doing, that seems like an excellent opportunity to expand that offering.
Yeah, about a year ago, we started getting a lot of interest in telemedicine, and a lot of it came from the pediatric group. You know, your 1 month post tonsillectomy, adenoidectomy, you know, people who are doing otherwise well. And in our system, obviously, we've really embraced this, but it just begs the question of how much do we need to see people? And you're exactly right. How much do you need to scope? Dr. Ebert, like, do you see this impacting your typical post-sinus surgery regimen, or do you still feel like those scopes are 100% necessary as you're doing them now?
In general, from a patient outcome, I think the majority, at least the first postoperative visit, which is usually a week or so after surgery, and possibly the second, I can maybe extend it if they're doing well after that. But in general, for outcomes, I think 1 or 2 early visits, it would be important for the patient. But extending after that, I think like you said, the allergy practice, that is a prime space for a video visit, because you can refill their allergy medications or their EpiPens, especially if they're doing slit at home and they're doing well with it.
Dr. Dawson, what do you think?
Yeah, I think the awareness of what's going on in the community is going to be key here in terms of modifying any post-op schedules. Right now, we are plateaued and heading down in number of cases. So every reason to think we can just keep things on the same schedule that we've always done. But I think I need to be aware of what's happening in our system, as well as in the state, as well as in our local community with the virus, and whether or not there's an upsurge or not. Probably need to modify or move things out.
Yeah, that's extremely thoughtful. I mean, we're all working off the hypothesis that this is going to continue to fall, but I think we're all suspicious that we are going to see rising numbers, unfortunately. And, you know, it begs the question of, do we need to be more cautious? Are the hospital systems going to be protected because we're already masking, we're already doing all these things? But it certainly is going to stretch the disease longer than it otherwise would have been. Dr. Lowry, are you going to modify anything you're doing with your postoperative schedule? Are you limiting what you're doing to prevent a lot of postoperative follow-ups?
I am right now, I haven't changed it, but looking forward probably will, because we have pretty significantly limited our clinical volume in order to socially distance people and keep people out of our waiting room. So we have lengthened appointment times, people are staggered, there's less providers, and so I have less clinical spaces in my day. So right now it's not a huge deal because people are slowly trickling back in. And while we were, down 80%, 4 weeks ago, now we're down 50%. But at some point, hopefully we'll only be down 30% of their volume. So something's going to have to give, because I would like to see new patients and I would like to be able to keep on providing them care. But I only have 16 spots or 14 spots during the day. What am I going to do with those 14 spots? So some are going to have to become telemedicine, which is a great opportunity for telemedicine, I think. And you can intersperse them between patients. Now the whole, as you said, there's many hiccups in that whole process. We've experienced them as well at figuring that out. Patients at least in the Bellevue area, expect their phone call at, 3:30 exactly. At 3:31, they're calling our office saying, why hasn't, Dr. Laury called me for my 3:30 appointment? Because I work at Microsoft, my time is very valuable. So we're working through those processes and teaching about ranges of appointments. But I think, anyway, long story short, I think we'll be switching some of those patients to more telemedicine, post-op tonsils, different patients that, are allergy patients, like Dr. Wilson said, are great for that. But so it will change.
We definitely have also some logistical things that interfere with the number of patients. To avoid having patients in our waiting room, they all wait in the car. So we have to call them on the phone and say, hey, we're ready for you. You have to come up. Our clinic's on the 3rd floor, so there's basically an elevator made for like 3 people. And so we can only have 1 patient at a time coming up, and we have 4 providers in the office. And so logistically, it's got to be very timed and thoughtful. And so there's definitely going to be a limit on the number of patients we can see until this settles out.
And I think that's very thoughtful, because a lot of the ways we see patients, having multiple providers in busy clinics, exactly what you said, limiting who's in the waiting room, considering one-way walking in your clinics, how you're airing out your clinic spaces, how you're cleaning your clinic equipment. This is all stuff that's becoming all my system talks about. For the sake of respect of everyone's time, I just wanted to go around and basically ask you, do you feel like we have a good grasp on this? And what I mean by that is we're used to being reviewers for journals, and you're seeing well thought out long-term projects, data-driven, randomized control trials. And what we're seeing now is a lot of information put out extremely quickly, some of it anecdotal, some of it one provider experience somewhere, and it leads to a lot of, frankly, concern. And so do you feel like where we are right now, you're comfortable with your personal protective equipment, you're comfortable where we are opening up again, and if you could change something, or if you could create some kind of barrier to reopening, what would it be? And if you're happy with it, just let me know if you're happy with it. We'll start with Dr. Ebert here.
As you were asking that, I was thinking, I'm as happy as I can be. Obviously, in a perfect world, I'd like to know more about this and where this is going to go. I think the fact that there's a lot of uncertainty about how long it's going to last, and vaccines, and how many times do you have to test somebody if they've been out, and if they're a patient of yours, do you test them once? So you have to test them every time. There's a lot of uncertainty in that sense, but I think we're doing as best we can with what we have. Knowledge is changing every day, and so we're changing what we need to do based on new information, and when it comes out, we implement it. But I think, at least in our practice in our state, we're doing the best with what we have.
Yeah, I couldn't agree more. Dr. Wilson, thoughts? I mean, obviously, you're in a good place. I don't believe that Utah was hit as hard as other locations, but do you feel like where you are, good grasp, you have what you need in terms of PPE, and you're ready to move forward?
Yeah, I agree with Dr. Ebert that, I think we just do the best with what we have. I've always, since this ever started, I've always felt like there's always a balance between doing too much and too little. And that applies to our whole society and economy, and our goal is to minimize suffering, to reduce risk, and to optimize outcomes as best we can. And so that might mean taking a little bit of risk here for more reward there. And that risk-reward ratio seems like it's ever moving. That target is ever changing. And so I think it's our job to stay on top of the literature. You're right, it's not robust literature. It's very anecdotal and word of mouth and small experience. But I think it's our job to do our best to collate that in our own practice, in our own mind, and do the best that we can for our patients, and for our practice, and ultimately for our society.
And what do you think, Dr. Dawson?
Yeah, I'm actually, I'm impressed with the amount of information that's coming out on this. Granted, it's low-level evidence, but it's still a lot of discussion. I can't help but think that we're going to know tons in a month, 2 months, 3 months from now, and that's going to make a huge difference from how we practice now. I'm not comfortable that I know everything I need to know to protect myself about this. I mean, what's the point of a vaccine if it doesn't matter? If you were infected one time, you can become reinfected. What's the vaccine going to do for us? So I'm not certain about that, but I am comfortable in terms of how it's really made everyone in our staff. We really have had a high functioning team. We really focus on that in my clinic, a nurse practitioner and myself. And that we pulled ourselves together even more. We're closer in the social distance way, but still very close and working as that one outcome, as an outcome-driven organization. And so I'm really pleased with how we've kind of risen to the challenge. I hope that doesn't go away. I hope we don't get, personal protective equipment fatigue or whatever it's going to be called. But it certainly is for now. I'm very pleased, and I'm happy to get busy again and go forward. We are, I think, forevermore going to be limited, that we will do things much more slowly. I don't think it's possible for me to get back to a day where I'm going to do 15 cases in a half day. That's just not going to happen.
Yeah, I've had several people on my team say the same thing, that it'll be challenging to get back to where you were at your busiest, just because of the logistical hurdles that will be put in front of you. Dr. Laury, same question. Do you feel like you have a good grasp on it? And if so, or if not, what would you change? What would you want to know?
I feel too knowledgeable about COVID. I feel like I know everything about COVID, but I feel like somehow I know nothing about COVID, right? So I feel better this month than I did last month. I can tell you that. I think overall, what would I want if I could pick anything? I think, and just like everyone has been saying in the news and politically, and I think we need more testing. I think I need a better test. I need a test where I can swab someone's cheek and have a 99.9% chance of getting the answer right then and there and within 2 minutes and putting in a vial. If I could have anything, that's what I would like. And that I think would change a lot, maybe even more than a vaccine. But hopefully someone's thinking like that and is coming up with it, and it'll be here in a few months. So.
Yes.
I think that's well said. And I think that also it's times like this that we're so thankful to have the AAOA to be able to provide information in the emails that are sent out and to have these kind of events, because, we all come from different places, academics, private practice in different regions of the country have different concerns in terms of what kind of procedures you're doing, but to come together and discuss things in a thoughtful fashion is always valuable. And, I really appreciate everyone's time, and thank you so much for participating.
Yeah. I'll just point out that the AAOA website is a good source of information, not only other webcasts or Zoomcasts like this, but also a lot of the literature and things that are out there on COVID are on the website. So do frequent that.
Excellent.
Thank you guys.
Thank you all for your time.
Thanks.
Thank you.
Thanks.